I'd like to call the meeting to order for the Committee to Study Long-Term Managed Care. First order of business is to review and approve the minutes of the previous meeting. Is there a motion to approve the minutes?
Second.
We have a motion and a second. Is there any discussion? Lacking any discussion, all in favor of approving the minutes say aye.
Aye.
All opposed? And abstentions. All right. So at our last meeting, we agreed on a preliminary report. We issued that preliminary report to the various parties who are entitled to receive it by statute. At this stage, what I would like to do is see if we can come to agreement on a final report. I have drafted what I think should be in the final report. Having said that, I think we are, we may issue a final report that has more than one recommendation if we don't necessarily come to a common agreement on what that should be. So I have already shared that draft with my colleagues on the committee. Have not heard any, obviously we have not discussed it and haven't heard any feedback on that, but in the preliminary report we had outlined 4 potential solutions, 4 potential options. Number 1 being to maintain the status quo, number 2 being to adopt DSNP, number 3 being to adopt the HCBS carve-out model, and number 4 being a full speed ahead on managed care for aging population. We did previously already agree that ABD and developmental disabilities should be excluded from any consideration at this time. So with that, let me share the recommendation I would like to make, and I'll just read from the draft that I put together. OB3 made major changes to Medicaid, and many of the rules and implementation details have yet to be determined. It is therefore difficult to determine with certainty whether or not a managed care model for long-term services and support could deliver optimal value for granted staters. Furthermore, states that have implemented long-term managed care support services have shown mixed results, suggesting that the detailed components of any plan would need to be carefully considered to ensure that the intended cost savings could be achieved. Finally, numerous changes in Medicare, Medicaid, SNAP, and other federally funded programs will require significant bandwidth on the part of DHHS, making it especially challenging to implement large-scale changes at this time. And in the draft, I say the committee therefore recommends, this is again my recommendation, that New Hampshire should consider adopting DSNP, enabling MCOs to provide more coordinated care for dual eligibles. By integrating benefits, MCOs can reduce duplication and better manage high-needs populations, including those requiring long-term services and support or behavioral health. Enrollment in DSNP would be voluntary, so patients who prefer to receive services as they have done in the past may continue to do so. DSNP would provide an opportunity for MCOs to implement frameworks to support long-term managed care service and support. Should have said long-term services and support, rather, making it easier to transition to a managed care model in the future if the legislature should choose to implement that policy. So that is the recommendation I think the committee should make. Having said that, I am certainly open to the idea of a majority opinion and a minority opinion, if more if my colleagues on the committee should deem that appropriate.
I think these recommendations that you're making, Chairman Caulfield, make a great deal of sense, and I would certainly concur with them.
I just have a couple of questions. Basically, I agree. And at our last meeting, I think you posed a question to Director Lippman to ask him if he knew if the federal budget, once it's approved, would incentivize states to move to DSNP. Did you ever get a response on that?
I don't recall asking the question. I don't recall the response, but I'm sure if your memory may be better than mine, so I will ask Director Lipman to come forward and offer his thoughts on that.
Good morning. For the record, Henry Lipman, State Medicaid Director. I did look at the OB3 bill and didn't see something specifically in there regarding that, but I can tell you in the Rural Healthcare Transformation Funding, there are incentives for states to be looking at DSNP and dual, dealing with dual eligibles.
And I have another question, if I could direct it. So would this recommendation hinder or support or parallel what you had mentioned that you were already looking at this or exploring the possibility? How would this recommendation affect what's already being done?
I think it would be in alignment with that direction, and it's in alignment with what we already had put in the managed care contract, as the state would have the right, with appropriate notice and what have you, to move in that direction.
Those responses having been received, I agree with the majority report.
Thank you. And Director Littman, I'll invite you if you have any further comments on what we're proposing to recommend as a committee.
I feel that based on what you heard and kind of my feel for the situation, that DSNP is a good step forward to try to get integration, so would be supportive of it. I think the timing of it, I think in terms of what the managed care organizations needing to get there, because we want them in the same insurance company for both Medicare and Medicaid, making sure they have the runway to do that, and we have the runway to implement it, because there are federal deadlines for when you can do certain things.
Great, thank you. And then I guess the only other comment I would have is, I know that if you have presented us with some information about DSNP and PACE together, from the research I've done around PACE, I understand that it would be feasible really only in the southern tier of the state or the more populous areas of the state. I guess my conclusion on PACE in particular is that I'm neutral on it. I've heard some positive and negative, but that's my personal position. Again, I can't speak for the other members of the committee, but I think the looking to DSNP as a sort of step forward without full-blown long-term managed care adoption, which I think is a very big and potentially disruptive step at a time when the department is already having to grapple with a whole lot of disruption coming down from OB3. So,
I guess let's just one more comment on DSNP. There are different sort of flavors of DSNP, and I just want to make sure in terms of when you use that term, where you're thinking we would go is, and what I was thinking I was hearing was that we would integrate the Medicare benefit with the Medicaid benefit as a starting point, and that we weren't necessarily bringing more into it than that. If I'm mistaken on what you were trying to convey, I want to make sure that I'm clear on that.
I would say personally, I think we're not as concerned with understanding that level of detail in terms of how it's implemented. One of my concerns is, I wanted to make sure the program is voluntary. I understand that there are no states currently that have implemented DSNP that require enrollment in it. It's voluntary. Some are opt-in, some are opt-out, but there's always an option for patients to make that decision themselves, which I think is something that we all believe is important and certainly of concern to patients. So, yeah, and in terms of the timeline, again, I think you laid out a timeline. Whether or not that should or shouldn't be more aggressive, I think, is a longer conversation and probably not one that we want to have as this committee. But again, the department is having to grapple with a whole lot of change in the next 2 years, 2-3 years, as a result of things happening at the federal level. So I think we'll look forward to seeing how that plays out.
So going back to PACE, I do think that I know David's here from Hillsborough County. I think in terms of looking at that component, I think it requires, I think, a little bit more study in terms of the risks that the counties would be taking on and how you would share that risk potentially with the state. I think there's also it's a little bit competitive with the volume of people that we have in the Medicaid program. We are with the changes that have happened at a state level with respect to going back to pre-pandemic eligibility criteria and the other changes in OB3, that one of the things I think about is making sure we have adequate size in our program to maintain 3 MCOs, because that's the best position for patient choice and state costs. But I do think that PACE, there are models that are out there about, other than in urban areas, there are some PACE programs that talk about rural, but I don't know that the question's any different in terms of, if you don't have the physical structures to provide certain services, you're taking even on more risk. And so I think that's a conversation for another time.
I will, since you brought up the sort of the question of MCOs, one of my concerns is, and we haven't really voiced it here, or I haven't voiced it here, is making sure that we have adequate patient choice. And right now we have 3 MCOs. If those MCOs, as you have suggested, we're minimally viable for 3 at this point. If we move towards this DSNP model, we have a role for those MCOs to play. It's a more viable business model for the MCOs, but that by extension increases patient choice, and it increases state leverage, and potentially, as I understand it, DSNP potentially helps us to optimize the number of federal dollars that are coming in, which is especially critical at this time. This afternoon, I'll be sitting on we have the last meeting of the MetDish committee, and that's a big concern. We want to make sure that we are optimizing New Hampshire's receipt of federal dollars so that we can make sure that people who really need it are getting it. So, thanks.
Thank you. I agree with all that.
Thank you. So, are there any further proposed changes? Any further comments from members of the committee?
I think we're good.
Okay. So, do we have a motion to accept the draft language as I provided it, and issue that as our final report?
Yes, I move.
Second.
So move.
All right. All in favor say aye.
Aye.
All opposed, nay. All right. With that, is there any other business for the committee? I don't think there is.
I don't think so.
All right. I want to thank everybody who's been here supporting us in providing information, helping us to better understand this rather complex issue. And with that, we will adjourn. Thank you very much.
Thank you.